fascinating. Having produced kidneys out of urine, we don't have to forget waste things. It might be useful. Okay, now my dear friend, Peter Wilson. Come here, Peter. Let me look for your long video, It's just, I'll try to find a minute to say something about you. Okay. So, Peter Wilson here is such an extraordinary physician, but a human being, better. He is professor of medicine in the Division of Cardiology at Emory University School of Medicine, professor of public health, global health epidemiology in the Rollins School of Public Health at Emory University, and director of epidemiology and genomic medicine at the Atlanta VA Medical Center. He graduated with the BAs from Yale University. I will not mention the year, just to protect us, and received his medical degree from the University of Texas Medical School at San Antonio. He postgraduated medical training took place at Duke. Well, he got a certificate in internal medicine and endocrinology. He was previously employed by the National Heart, Lung, and Blood Institute, director of laboratories at the Framingham Heart Study, professor of medicine at the Boston University School, and professor of medicine at the Medical University of South Carolina, and we can go on and on and on. So he will tell you himself what is it about Peter Wilson.
The most refreshing thing of this morning for me was this picture with I didn't have gray hair. I had much more hair. For those of us who are older, they know what I'm talking about. So I have two talks. This first one is about metabolic syndrome, and it's largely going to have Framingham data from the beginning. Then it's going to end with all these new medications, and don't hesitate to ask me about them because I prescribe many of these medications in my endocrine clinics. So we'll go ahead. I have no disclosures. I have had no relations with industry really for the last 15 years because I've been on the U.S. cholesterol guidelines, and I've also was served for many years for the Food and Drug Administration for the Endocrine and Metabolic Diseases Advisory Committee. So I was related to the committee that approved many of the drugs we're going to talk about 10 years ago. We've had them now for almost a decade. We're going to go through observational data, clinical trials, and I'm going to show a lot of data. I'm going to give you population data. You're going to get a feeling for what is the use of these newer medications, and also partly in contrast to the older ones. And I hope to build on what the previous speakers. It was great to hear about the Nobel lecture really related to mechanisms, and I'll try to build on some of that. And also, we even heard some mention of kidney function in the last presentation and SGLT2s. So just to share with you some of my take on this as a clinician. So it was started by Jerry Reaven at Stanford maybe about 30 years ago, and others, is what is the metabolic syndrome and what happens before you get diabetes. And we've had various names. Nobody likes the names: impaired glucose tolerance, et cetera, pre-diabetes. What happens before you get diabetes? And I'm mostly talking about type 2 diabetes, which is 95%, at least in America, for what is diabetes. It's especially obesity related. It happens starting in middle ages, but no longer. It's now starting at younger and younger ages because of obesity, especially in Western Europe and the States. And so the idea came up of risk factor clustering, and Jerry Reven was one of the people who put this forward. And how do you put this together? And so this was actually first put together by one of my colleagues, James Meggs, who's now a professor at Harvard, and Ralph D'Agostino, and it's using mathematical constructs. And this was the beginning, actually, of artificial intelligence. And we now use all this, and those who are population genetics know what I'm talking about a little bit, is we have principal components. How do things cluster together? And this is what you're doing when you're asking AI to do something on the computer. You're looking for their clusters, and then it's going to spit back that sort of literature related to it. And so you can do this mathematically with a handful of variables. So here I have about 8 or 9 variables, 1, 2, 3, 4, 5, 6, 7, 8, 9 or 10. Of course, I could have 10 constructs. That's not any helpful. It's just like asking 10 different people in the name. Give me your full name, and then I just can sort of, as opposed to how about certain people with different backgrounds, short people, tall people, people with kidney problems, people with heart problems. So other ways, and this is now using it for risk factors. So we're going to try to predict whether you're going to get heart disease, or you're going to get kidney disease, you're going to get liver disease. More and more things are being related to this. So this was the first construct, was this just actually start with this central core. And you can have these extras on the side, the blood pressure, and then glucose information. But it started out actually more with insulin because it was thought to be insulin related. But you can use as surrogates these others. So you can guess how some of this is going to go together. My guess is as I start to create the constructs, the glucoses and the insulins are going to hang together, right? Because they're going to be highly correlated. What we're really doing with principal components analysis is we're looking at what goes together. And that's what happens. So this is the mathematical result when you do the programming for that. And you come up with 3 major domains: the central metabolic syndrome, you have a hypertension element, and then you have an impaired glucose tolerance issue or hyperinsulinemia. So there are different ways to think about this. And why is that important? Well, if you're going to just go after the central metabolic syndrome, where are you going to focus? Where are you going to focus? Well, you can see HDL and triglyceride. Okay, I'm going to focus. I have some elements that's lipids. Then you see waist, hip, and body mass index, which are adiposity related. But then if I get those, maybe I'm going to get blood pressure as a benefit, so to speak, okay? So I'm already thinking lipids. I'm already thinking something related to adiposity, and that's going to bring in blood pressure favorable effects. And then I'm thinking glucose and insulin. So if I can do something for those, but the point is I'm probably not going to have any one medication. I'm going to use different components, okay? I have different medications that are actually going to target different elements of this. So we created, and these are lines drawn in the sand. These are the American and mostly the Western European lines for the adult treatment panel metabolic syndrome criteria. Can you guess who adopted those? Almost the entire world, with one major exception: Asia. So Asians said, we generally have different adiposity and we have different heights for sure. So they especially modified the waist circumference, but many of the others, they really kept pretty much the same, okay? The other one that's been going along is, where do you start for hyperglycemia and hyperinsulinemia? The glucose originally was 100. And then you would say between 100 and 125, which is pre-diabetes. Well, that's really important. What about 90 to 100? And so you'll get others who will do various definitions of sensitivity analyses. Is where does diabetes start? You know, like Peter Bennett for the Pima Indians, which is one of the major studies going 50 years plus, would say it actually starts at 80 and 90 for a fasting glucose. So now, this is an example. The top of this slide doesn't show very well. I apologize. So these are cardiometabolic factors and risk for outcomes. These are just the Framingham offspring, second generation men, based on about 2,500 men. And how many of those factors that you had, okay? So the more you have, which is in the orange, as you can see, you start to say, wow, type 2 diabetes, that just goes through the roof. 23 times the relative risk for developing type 2 diabetes if I had that. Now, but you also see moderate, and they're not insignificant. These are all statistically significant once you get 2 or 3 of these or more of these risk factors. They're all significant for cardiovascular disease, and hard CVD is myocardial infarction or stroke, and then total CVD will also include milder things such as angina pectoris. So now you have this tableau said, all right, these factors count, and we still didn't have any medications really other than, and we created this sort of concept. I've never published this slide. I guess I should, and it's been around for a while, but we start out with adiposity, and several of those factors lead to, as I've mentioned, the lipids and also the blood pressure. But then you have all these other risk factors that are really not related to the metabolic syndrome, which increase your risk for cardiovascular disease. And then you see as the major over to the right, you see cardiovascular disease risk. But that is not the way everybody gets heart disease. And more people are getting heart disease, and they pass through something else. They get diabetes first or borderline diabetes first. And that's, you sort of say, well, is that a big deal? Yeah, for instance, in the VA in the United States, we have 30% of our veterans have diabetes mellitus, 30%. The overall impact of diabetes around the world is probably in the 10 to 20% range. But I'll tell you, for instance, 2 nights ago, we had the greatest overeating experience probably in the world. What was that overeating experience? The Super Bowl. More people overeat on the Super Bowl than any other time, and it goes every country in the world. I walked through the bar here on the way to a reception last night, and the bartender was watching reruns of the football game. He was watching the intercepted pass that sort of led to the end of the game, and that was the end of that other team. The Patriots, they're Patriots, but they couldn't keep up with the Seahawks. So the point is, America, they talk about how many pizzas, you sell more pizzas on the Super Bowl night than any other day of the year in the United States. And who knows what happens for, comida rápida, all parts of Latin America. You're selling a lot of food that we really shouldn't be eating in excess. And this is for the younger people. You folks, you can do it now, but wait until you're a little older. You're not going to be able to do it for much longer. But now we have metabolic liver and kidney disease, also part of diabetes or part of the metabolic syndrome. Wherever I put type 2 diabetes, I could almost put metabolic syndrome, because if you sit in the state of having metabolic syndrome for a while, you're likely to get type 2 diabetes the longer you go, okay? Now, what do we have for medicines? All right, so I'm old enough to have the medicine even before metformin. We had fenformin, which caused increased signal for lactic acidosis, but that got replaced by metformin, which is a fabulous medication, first-line drug. Then we had sulfonylureas. Sulfonylureas were originally used to treat diabetes, and we've even used them to treat pre-diabetes, borderline metabolic syndrome patients. Those, the trouble with glipizide and glyburide, the others, they cause hypoglycemia. Insulin and sulfonylureas are the only things that cause hypoglycemia, and that is important for treating the metabolic syndrome. I can't treat a patient really very reliably with glipizide for metabolic syndrome, because if he takes too much of it, he's going to get hypoglycemia. And if he's a 50-year-old man with heart disease risk factors, he may get arrhythmias, he could have a heart attack, etc. Then we had gliptins, which are also DP, these are incretin drugs, not very potent, but okay. Then we had the new therapies, and this has been the last 15 years. So any young medical scientists or students or residents, you've heard about these drugs, but we didn't have these drugs at all for most of my career. So SGLT2, and I always remind the medical students, how do you remember which is these newer drugs? So G has glucose in it. So why was that so important? That was another, fundamental basic science discovery. It was children who had glucose in their urine, but they had normal glucose in their blood. I'll say it again. Glucose in their urine, normal glucose in the blood. That's because they had a receptor defect in their kidney, and they were spilling glucose at a glucose of 150 in their blood. You won't forget that. And then as it's dragging the glucose out, you're taking some sodium out. So it acts like a diuretic. Hey, this is a good drug. This is going to lower glucose. Maybe it's going to affect the sodium. Maybe it's going to be good for heart failure. Maybe it's going to be good for heart disease in general. And in fact, that was the case. So the SGLT2s, for instance, and the first was empagliflozin. I'll show you the results of that trial, the major trial. It was positive. Virtually every one of these trials has been positive, and it's moved beyond diabetes, and it also works for heart failure patients. Yeah, so anybody at risk for heart failure, recurrent heart failure, fabulous medications. And then the next one is the GLPs. So the GLPs are glucagon-like proteins that have a receptor agonist effect. So those medications work generally to slow gastric emptying, and they just prolong the effect of normal metabolism. Well, the first drug, exenatide, was sort of a twice-a-day drug. You could take it once a day, but it's twice a day. Liraglutide, the next one, really once a day. And then semaglutide once a week drug. So it led to a lot easier adaptability for persons who've never taken an injection. And then the potency is pretty big for all these. Now, how do they work? They make you upset on your stomach and you don't want to eat. So that's rather fundamental. So most of the patients, we start out very slowly with all these. The most commonly used one is semaglutide at this point, and there are many more coming, so many more of these drugs. And these are injectables once a week, but the orals are coming as well. And then the second generation, which has a dual mechanisms, is tirzepatide. And then there's a third one, of three mechanisms, is tetratide, which is going to be available in the next year or so. And now there are oral medications. So I'll show you some of the data, and that's really what this is going to be about until we finish up. So this is just to remind you, remember we started out with metabolic syndrome, and my favorite word for this is metabolic sabotage. So for those of you who remember where the word sabotage comes from, it's a French word. It comes from saboteur. And saboteur is how do you mess up a factory in France? And you throw the shoes into the machines. And the shoes are your sabots, S-A-B-O-T. So this is a way of taking very low technology, in fact, working at multiple systems to sabotage your metabolic syndrome so that you won't develop diabetes and or you won't develop heart disease. So quickly, I'm going to skip by this. We can't just use glucose to treat insulin or sulfonylureas because you get hypoglycemia. This is VA data from our own report a few years ago. Once you get a hemoglobin A1C less than close to 6, you run into the risk of having arrhythmias and cardiovascular death. So these newer drugs do not have major effects on glucose, which is fabulous. Okay. All right, here's the EMPA-REG trial. Is this a positive trial? Would you vote for this? In fact, I was on the committee that when we voted. It was a big split vote. This was the first drug in the class, and 14%, and it saved lives. This is the CVD events of risk, but it also saved lives. It led to approval, and all the other drugs in this class have also been approved. Here's the LEADER trial. This is the liraglutide trial. This is the once-a-day injectable, also positive. Remember, this is now a GLP, the first major GLP that was used for trials. Now, here's another one for CVD death for liraglutide. But these are the drugs. The next ones are the semaglutide drugs. And the semaglutide, there have been about at least 4 trials. They're all called STEP trials, step 1 through 4. As you can see there, look at that. Change from baseline percent on the y-axis, 16%. If you lower weight only 5 to 10%, and I've been around using a lot of those drugs over the last 30 years, we do not affect heart disease risk. We do not affect major outcomes. We don't really affect diabetes very much. We certainly don't affect survivorship. But now you start to do that with semaglutide with a 15% effect. Now, here's the bad news. If you stop the drug, you don't want to be in the group that got switched to placebo in that trial, right? So this was a switch trial. They went for approximately 20 weeks, and then they stopped. And then those who got switched to placebo regained their weight. So you need to stay on these medications, okay? And here's the more recent one with a tirzepatide with different dosing. This is a different dosing trial. You know, the 10 milligram, 15 milligram, very equivalent. And now look at the y-axis again. Pay attention over there. And you're now getting greater than 20%. And you're going to get that with the next generation. This has become the most potent in the class that's available. And it's the trouble is these are injectables. They're once a week, and they're expensive. And not all the world can afford these. So this is my last slide. How are we doing generally at 1 year? So at the top are the older studies, okay? Greater than 10% is in orange, and greater than 5% is in blue. So greater than 5% is going furthest over to the right. You say, most of these drugs really can get 5%, virtually everything in the last 15 years. But now look at the medicines in orange. Hey, we're doing much better. And the medicines that I was showing you towards the end there, that's where all the newer medicines are. They're all greater than 10%, typically greater than 15%, and probably more than 20% in the future. So thanks very much.